Hi, everyone, and welcome to OR Today webinars. We have a great presentation for you today by Brooks DuBose from LeanTaaS iQueue for Operating Rooms Implementation Team, as he explains where the opportunities lie and how to drill down in order to come up with actionable steps and strategies for meaningful performance improvement. OR Today would like to thank our sponsor, LeanTaaS. LeanTaaS develops software that increases patient access to medical care by optimizing how health systems use expensive, constrained resources like infusion chairs, operating rooms, and inpatient beds. Over 200 hospitals across more than 40 healthcare systems and 2,100 ORs rely on iQueue for operating rooms to maximize OR access through seamless scheduling practices, ease of access to the ORs, and optimizing OR utilization. LeanTaaS has helped hospitals quickly and safely recover elective surgery backlogs by unlocking OR capacity through the lightweight, cloud-based platform and quickly achieve remarkable results, including increased case volume, market share, and 10 times ROIs, even during very challenging times. For more information, please visit LeanTaaS.com. For nearly 20 years, OR Today has provided perioperative and SPD professionals with up-to-date news and information about their profession, including new guidelines, techniques, and equipment, as well as practical information for career building, problem solving, and overall well-being. Please visit ortoday.com to sign up for your complimentary subscription. Today's webinar is eligible for continuing education credit by the State of California Board of Registered Nursing. You can obtain your certificate by completing today's post-webinar survey. More details on this at the end of today's webinar. We'll wrap up today's presentation with a live Q&A. You can submit your questions at any time during the presentation by using the questions feature on the GoToWebinar dashboard. We'll get through as many attendee questions as time allows. As I mentioned earlier, today's presenter is Brooks DuBose. Brooks, you may begin whenever you are ready.
Wonderful. Thanks for the introduction. My name is Brooks DuBose. I'm a product implementation specialist and project manager at LeanTaaS. Really excited to have everyone with us today, and hope we can give some insights into some of the studies that we've done and how through iQueue for operating rooms we can help improve your utilization of your operating rooms. So today's presentation is titled "Don't Sweat the Small Stuff." So we'll dig into why we believe that first case on time starts and turnover are not the most important metrics that you should really be targeting to improve your block utilization, and what we believe is the main focus, and then how to do so. So in today's presentation, first off, we'll start with just who is LeanTaaS and what do we do, and then I'll review with you a case study that we partnered with one of our longest standing customers in order to study the impacts on block utilization and the forces and drivers that impacted the most. And then as a result of our findings, you'll see that we learned the largest problem is not what you typically think, that scheduled downtime, as we coin it, is really the biggest driver to unused block time. And then I'll walk you through how iQuue for operating rooms has tools and processes that can help you address those forces and improve your overall utilization. So first off, who's LeanTaaS and what is iQuue? LeanTaaS is a Silicon Valley-based healthcare software company with also an office in Charlotte, North Carolina. Our mission is to help you unlock your scarce capacities, your scarce resources, and really utilize those the most efficient way possible in order to improve your operations utilization on the margin without having to utilize or create any additional resources. LeanTaaS is a company that's been founded and created by a group of ex-consultants, healthcare leaders, data scientists from many different backgrounds in order to really use data science and predictive modeling and analytics in order to help unearth that capacity and improve those operations through our online tools. We work with many different hospital systems, over 40 and over 2,100 ORs, and with most of the major EHRs across the country. So we have a lot of in-house expertise into the EHRs and workflows. So we're able to work with our customers on extracting that data, getting it into iQuue, and then helping improve their processes through decisions that are supported by the iQuue tool. So this case study is sort of the birth story of iQuue in a way. We partnered with UC Health, our first customer located in Denver, Colorado, in order to use our analytical skills to tackle a difficult problem. So first, we wanted to understand what are the drivers to block utilization, and how can we implement a solution that can combat those and improve that overall utilization. So we focused this study on the Anschutz inpatient pavilion at UC Health. We chose this location because of its size. It's got 25 ORs, has high volume, hosts trauma cases. It's a transplant center, and especially because of its highly blocked nature. 90% of the OR time is blocked off. And so we wanted to use this as a sample to see where we can find opportunities to improve the utilization of that blocked off time. We began by studying that, and based on our math, came up with about 71% block utilization over the course of a year at this location. So block utilization, very popular metric that I'm sure many of you use at your organizations. Most simply put, it's the summation of all of the allocated block minutes divided by all of the in block minutes where a case was actually being performed, plus turnover time. One deviation can be if you allow to calculate all manual releases, or if you throw those out of that block allocation in the denominator. So overall, pretty standard metric that I'm sure many of you utilize that we're going to look into today. So when addressing poor utilization, the natural inclination that most peri-op leaders we've worked with is first to address delays from first case on time starts and turnover. So constant headaches and causing reductions in utilization every day. So UC Health, and when we partnered with them, had put lots of time and many projects over years on how to mitigate those and improve FCOTs and turnover time. While those efforts were not wasted, they only saw some minimal results that really proved not to be very significant. They were improving their flow and communication and satisfaction across the board, but still really not getting the best bang for their buck with all the effort that they had put into certain projects. So at this point, we started wondering what impact or what percentage do delays in FCOTs and turnover actually have on block utilization. So of that wheel there, what percent of the delays versus other reasons versus scheduled downtime is really contributing to reducing block utilization so much. So we started doing a study there. First, we wanted to study the impact on first case delays. We defined a first case as any case that started between 7 a.m. and 9:30. And then a first case delay was anything where the actual start time was later than the scheduled start time with no buffer. So anything that's late counts as late. And then did our calculation, and results were pretty astounding. Of the 16,000 minutes of first case delays, on average 3 minutes per delay per block, and that resulted in 2.1% of the unused block time. So pretty insignificant fraction of that underutilized block. So next, let's do the same thing with the turnover delays. Let's see what the impact is there. So we measured the turnover with a given budget, aggregated that, and came up with 12% of the unused time being attributed to turnover. So more significant than first case delays, but still a small fraction of that total calculation of the unused block time. So where's the rest of it? When we add that up, only 14% of that underutilized time can be attributed to first case and turnover delays. So we wanted to peel back that 86% and understand what does that make up and how can we address that? So we started thinking and brainstorming and came up with 3 factors that we really wanted to dig into. One being scheduled downtime, so any time that was scheduled but never utilized, last minute cancellations, and then case length overestimation. Of course, there's many other reasons and many other inputs and parameters that can contribute to block utilization being decreased, but these are the 3 we decided to hone in on and really wanted to analyze. So scheduled downtime, you can think of that as if everything on the schedule goes completely perfect, what's the best utilization you could possibly be? So any portion of time that was scheduled to not have a case counts as scheduled downtime. Last minute cancellations, we counted any case that was canceled within 1 week of notice, so pretty lenient there, trying to capture as much as we could. And then block by block, if the total scheduled time was larger than the actual time used, we know that that can be a big disruption as well. So I wanted to really take a look at the case length, and especially those that we overestimated. So the results were pretty eye-opening. By a large margin, the scheduled downtime accounts for the greatest majority of the unused time. Over 50% of that unused time was really scheduled as downtime. So wanted to really focus in on that first before addressing the other factors and understand how does this scheduled downtime appear, how we can monitor it, how we can address it and improve our scheduling patterns to allow for more efficient block utilization. So the implications that we reviewed and realized were the top factor is scheduled downtime. The current block allocation clearly does not align with the real demand very well. It's really hard to build a block schedule and completely match that based on the stochastic nature of the real demand of surgeries and cases. And then there's that paradox that some surgeons have more time than they need while others have less, so it's hard to balance. And then among that scheduled downtime, there are many blocks that never even had 1 case scheduled in it. So we wanted to find a way to unearth those and make that available, liquefy that, and still not penalize the surgeon who didn't use that time. So among many different solutions, we had really 2 different angles that we wanted to go. 1, a tactical solution, and then 2, a more strategic hierarchical solution. So the tactical solution is addressed by a module in iQueue called Exchange, really promoting more accessibility to open time, trying to make it easy to find open time, try to make it easy to create more time, really liquefy that market of block time that's not going to be used for others to be able to utilize. The goals were to create sort of a open table for OR time where with a click on a mobile device or web platform, schedulers and surgeons alike can go in and find that time that they need or release the time they're not going to use, hoping to really pack in cases into blocks and create a much more efficient schedule. And then the strategic solution was then, once we've sort of figured out how to meddle and work with the time that's already on the schedule better, to take a step back and align our blocks with our demand better. So get the right blocks, the right surgeons on the right days, which can be really difficult without the right data at your fingertips. We felt block utilization was really strict and broken, didn't account for delays or other reasons, and it wasn't surgeon-centric. So we created the collect module, which focuses on a new metric that we've called collectible time to provide a fair way to repurpose block time without negatively impacting physicians and their practices. So how can we address the scheduled downtime? The 2 different strategic and tactical solutions we just mentioned resulted in the development of the exchange and collect modules, which we're going to dig into today and show you how we do both of those processes. So let's hop in and take a look. So first, I'm going to start with exchange. And exchange really can be seen as an open table for OR time. So imagine your clinic and OR schedulers have access to a tool like this where any clinic on behalf of their surgeons can request any available time that hasn't been claimed or released from a mobile application. I can see what ORs have time. I can put in special requests like I need a robotics room. So instead of calling and texting, emailing, faxing over case scheduling details, or walking into the OR manager's office, I can, with the click of a button, put my hand up and say, hey, I want to use this time and I'll use it well. If I need time on a day that's not available, I can imagine being able to put your name on a waiting list, sort of like an Amazon wish list, if you will, so that in case any time opens up on that day, please notify me. I'm ready to take it. And then with one click from my phone, I can request that time and submit my case scheduling information. On the flip side, if I realize that I'm not going to be able to use my block time because I'm on vacation or at a conference, the ability to release that time within 2 clicks rather than calling and sticky notes and emails and many different mediums for communicating releases that don't ever actually get completed on the block grid. So making that really easy helps us unearth and create more time for those who don't have time to access, and everyone wins. So I'm going to play a quick video here. In the top right, you should be able to see sort of the workflow of a scheduler going into iQueue to requesting time. So this essentially is translating what's currently a paper-based or manual request and release system and converting that into an open table-like marketplace on the web or on a mobile device. So just like we don't call travel agents or call hundreds of restaurants to make travel or dinner plans anymore, we go to some central market like Uber or Skyscanner or OpenTable or Resi, which pulls all that demand together and then with a few clicks shows you that availability. So it's the same concept as a lot of the tools that we use every day, but putting that into the OR. And really what ends up happening is a much more streamlined process where the requests and releases for blocks get communicated to the scheduler in a simple portal where they can approve or deny and place that time on the grid. And really the big win here is from the surgeon perspective. The surgeons can get chunks of OR time when they need it, and you as an institution never lose time on the margin. Because even with the best block allocation in the world, we know that life doesn't work according to a block schedule. As hard as that is to believe, things will come up and there will be different disruptions. Chances of me using my block time 100% are pretty low. So the big benefit there is that no one really loses. If I put my hand up and say, I don't need this block, I'll put it back in the pot for others to use, I'm just giving away that one instance of time that I wasn't going to use anyway. I don't lose my Wednesdays, I just lose that one that I wasn't going to be able to use anyway. So on the flip side, whenever there's a date that I need to perform a surgery, if someone else releases that time they're not going to use, then I'm able to utilize that. So through this online platform, creating that culture of really easy to release and relinquish that time I'm not going to use, if everyone's a team player, the whole organization really wins. So also within Exchange, of course, we can't just show any time that's not blocked to be open to any party. We have a lot of different constraints that we can build into the application to ensure that only appropriate availability is shown to those who are requesting based on certain limitations, such as equipment, staffing, and only cardiothoracic cases happen in these rooms, or do I need to make sure that if a case is happening in this room, it's going to have a robot? So there's lots of checks and balances and configurations that we can put in place so that we're truly showing availability to those who can use it. And there shouldn't be any instances where I request time but I'm not credentialed or don't have access to that room. So it takes a lot of the decision making out of the process. In addition to be able to request time, Exchange allows surgeons to easily release that block time that they're not going to use, as we've discussed. And as we know, most surgeons, even if it is easy to release, aren't going to be sitting around thinking about which blocks they should get released for this next 6 months. So what we do is try to be proactive and suggest the blocks that could be released. iQueue monitors booking patterns and identifies allocated time that's likely to be underutilized by looking at a surgeon's historical scheduling patterns. Proactive release reminders, like you can see on the screen here, are sent to the surgeons based on those booking patterns and are predictive analytics to encourage surgeons to release that time further in advance that they know that they're not going to use. So it creates more of a open time which is available for others to pick up. Think of it like a dentist's appointment where you get a text that says, hey Brooks, are you going to show up tomorrow for your appointment? Click yes or no. It's really the same thing. And based on your auto release schedules and how often that surgeon books time in advance, it could be 15, 18 days in advance, we'll send that notification saying, hey, by now you usually have some cases booked. So if you're not going to utilize that, how about open it up and give it to the rest of the pool to use? And if you are going to use it, go ahead and schedule some cases. It also really creates that accountability, because if you can say, Dr. Saltzman, you've received this message three weeks in a row, that's your block, and you never release it and they weren't used, it creates that kind of circle of accountability as well. So really trying to make it easier for surgeons to release time, as well as being proactive about that, putting a notification where they can click yes if they want to release it or able to release it, really creates that culture for opening up more and more time that can be utilized. So now that, with the combination of this Amazon wish list idea, where I put my hand up and say I want time even though I know it's not available right now, is a beautiful circle. It's extracting demand signals by making your surgeons say that they can use that time even if it's not available, and then get an iQuue data to go back and look for people who have time on those days that are probably not going to be utilized, and asking them to release it so that those who need it can then utilize it. So you can see how it's a fully closed loop there, helping unearth that demand and then match it to the supply. Another big benefit and win here is how the scheduler's life and work day is really changed. We know that the last mile of this decision making still needs to be exercised with some human judgment. Because remember, we talked about the request for special equipment, or is the equipment ready? Is anesthesia available? Is nursing staff there? All of those checks and balances still need to be done by some human intervention, some OR manager or scheduler on your side who gives the go ahead and final thumbs up. We don't want to be a system that completely tells you what to do and where to schedule and how to run your operation. We know that there's so much tribal knowledge there at the hospital that's really got to be that final gateway before entering things onto the grid and finalizing them. So if you see this video, you can see that the scheduler's life really changes from 3 different monitors and email blasts and phone calls and texts and people walking into their office and faxes to one streamlined task list where they can manage any requests to access new block time or to release that block time, and they work off of that list in order to streamline the scheduling process. They'll check through each of the requests. If something doesn't work, they can deny that and send a reason to why it's not going to work for that specific surgery, or ideally go ahead and schedule that on the grid and send confirmation back to the scheduler and surgeon and patient in advance. So the results of this have been really staggering. This data is through January 2020. So at that time, our average customer was seeing a 6% increase in room utilization, which is really magnificent when you add up how much OR time that is. The idea here is that we're filling the ORs better, a never losing a block, a no block left behind mentality, if you will, and in financial terms, and in comparison, it's like day trading compared to reallocating your portfolio. Liquidating that market, making it easier to find and utilize that time can really help streamline the scheduling process and efficiency across the board. So that's the first module. Let's hop over to collect and talk about how we try to right size your block allocation from the start before we even are down to the level of that exchanging blocks. So this has more to do with the fundamental block allocation itself, as we said. the module is called collect, and it's fundamentally questioning block utilization and the policy on how it is set. And I'll explain to you why now. So here on this screen, you can see two different surgeons, Surgeon A and Surgeon B, each day and their block. The blue is use time when a patient was in the room, and the white is time when it was not used. So this right here is the problem with block utilization. Let's imagine that we have Surgeon A and Surgeon B, and Surgeon A is someone that does more predictably long cases. An orthopedic surgeon, do reasonably cookie cutter knees and elbows and hands, and can usually predict pretty accurately if it's going to take 2 or 4 or 6 hours. If I fill 10 blocks in 1 quarter and I'm Surgeon A, if I have 10 blocks in 1 quarter and I'm Surgeon A, and I fill 7.5 of those really well repeatedly, and only 2 of those completely unused, my block utilization is roughly 75%. So let's say I'm Surgeon B and I'm a neurosurgeon. There is virtually no way possible anyone can predict how long each of my cases is going to take due to the stochastic nature of the cases and work that I do. There's no way that I can reliably predict every one of those cases with any good estimation. In the end, I end up using all 10 days, and my block utilization ends up being 75%. So that's the dilemma right here with block utilization, is a metric to make block policy. If you took 2 days away from Surgeon A, you could be pretty sure that they're going to be able to get all of their cases done. If you took 2 days away from Surgeon B, pretty likely they're not going to be able to get all their cases done. And for Surgeon B, frankly, because you cannot predict the amount of time it takes to fit in a case, it's almost impossible for you to capture some of that time that's left at the end of the day on the margin. The biggest problem with block utilization here is that 1 minus block utilization means absolutely nothing. What exactly does 75% of block utilization mean? It does not mean, as you can see here, that we can take 25% of each surgeon's block away. It's not fair. It's not surgeon-centric. The way I could really look good as Surgeon A is I'll release my 2 blocks every single time, and then my block utilization is now 75/80. So I look much better than Surgeon B every single week. It's just that nature of surgery that makes it really hard to use block utilization as a metric. It makes sense across the board. There's so many different nuances and factors that go into different types of service lines and procedures and surgeons that you can't just look at one metric and judge everyone fairly. So let me introduce to you what we have coined as collectible time. It's a far more actionable, more surgeon-centric block measuring utilization metric. So let's kind of look into this graph here. This is, again, very similar to what we saw on the last page, where the blue is utilized time, the white is the unutilized time, and we see different sections of unused time. Let's start by saying we want to ignore the small grains of sand. The little white spaces, which we're calling non-collectible time, could be a 15-minute delay on a first case start. It could be half an hour left on the table at the end of the day, or it could be a turnover time that was 15 minutes longer than it should have been. I'm not suggesting that any of those things are okay to do. Definitely don't want to do those things, want to improve those things. But all I'm suggesting is those small grains of sand are not significant enough to collect and repurpose with another case. So instead, we want to look at the 3 types of time which you actually get some cases in: large contiguous portions of unused time, abandoned time, and released percentage beyond a certain threshold. So look at the gold stars, which are what we say are long enough periods of time that can be left on the table that could be repurposed for another case. Like the time in the middle of day on Jan 10th, time at the end of the day on February 22nd, or the morning of March 1st. And then what does long enough mean? It depends on the service line. It depends on the organization. It needs to be configurable. For orthopedics, long enough might be 2.5 hours, whereas for neurosurgery, long enough might be 5 or 6 hours. Point being, if you look at the history of how surgeons and service lines are using their block time, it's quite likely that if you stop thinking about block utilization for a second and start looking at 1 minus where there are large enough chunks of time being on the left on the table, then you actually have some repurposable time. And then second, did some of the surgeons or service lines leave entire blocks completely unused, like on March the 15th? Or are they hoarding their block and just not releasing it, even knowing that they're not going to utilize it? And if the way that you're calculating block utilization excludes the amount of time they've released, then you're doing yourself a disservice. Block utilization may be really good, but if they've released 35, 40% of the block time you give them every week, then it's just helping them out and not showing any penalization for them. So if you define collectible time as these sum of 3 things, large enough chunks of time left on the table, depending on what you consider large enough, the days that are completely abandoned, and a number of releases above a certain threshold that you define, and you can become very surgeon-centric. And by definition, collectible time means that I have looked at it over a period of time, and if you took that time away from me, you can be assured that I'll still be able to get my cases done. This module is a decision support tool. It doesn't automatically institute new block policies. It gives you the information to make those decisions in block committees to help repurpose and reallocate that block based on surgeon-centric methodologies that much more granular than a simple calculation over a monthly or quarterly percentage. So this module really helps peri-op leaders have fact-based conversations with their surgeons about their performance and needs. So digging in a little bit to actually utilizing Collect and what that looks like, you can see here we have the tool up on the screen, and what it does in this module is allows you to configure those thresholds that you want to define first. So what's the threshold to determine how many releases are acceptable? Is it 25%? Is it 30%? How much time do you deem as large enough to be collectible? And then filter that down to a specific service line or location, or to the specific block owners that you want to look at to create a report of those with a significant collectible time. The key thing here to remember is you can create multiple collectible tables. So let's say we want to be more strict and say that 2 hours or more is deemed collectible for orthopedics, and then we can create another table saying 4 more hours is collectible for neurosurgery. So you can really be as minimally and detailed and specific and surgeon-centric, service line focused that you'd like to be. So once you configure the tool, you'll see this report, which will have by block owner, by day of the week, by location, how much of their historical usage has been collectible. And unlike block utilization, this is much, much more precise. So notice we can see Dr. Weber on Mondays at the main location has 12 allocated blocks over the quarter, and based on the parameters we entered, iQueue deems that 5 of those are collectible. You can dig in deeper. In my conversation with Dr. Webb, we can have this screen up or report and say, Dr. Weber, look, you had 12 blocks allocated. We think you can get all of yours done in 7. We've been fighting over delays and turnover times, but what I'm really pointing out is if you just look at those gold stars in that picture, then that amounts to 5 full Mondays that I could collect from you and still not hamper your practice. And if you want to delve deeper, you can scroll through and see every single block, what was utilized, what was left on the table, what was completely unused, what was released, and generate a report to have that data-driven decision. So as we've discussed, Collect really gives you the tools and the data to have those conversations. Most of our customers will start out very lenient, really hit the lowest hanging fruit, those who really just leave blocks out on the table often. And that'll create that conversation, that culture of being aware of releasing your blocks so that one, surgeons just naturally by this process being implemented are releasing their blocks and being better stewards of their time. And then 2, able to be factually penalized or be willing to give up time that they currently have allocated. I've actually put in here a screenshot from a text message that received from a customer of mine. He's a director of surgical services at a large hospital in the country. Said that he got his ortho team to agree to give up 2 blocks per week. Was that possible with iQueue? Absolutely impossible. We've had a number of those instances where groups are seeing the data and able to understand it and agree to opening up more time and helping the system as a whole. So bake it into policy. Standardize your definitions, move away from block utilization, use collectible time, drive your block committee meetings with collect. That's our goal, and that's what we've seen our most successful customers do in order to create that culture of honoring and respecting block and ensuring that it is used most efficiently. So in summary, the big aha moment for us was when we experienced with all of the institutions that we've worked with is that you look at the chunks of time that are left on the table. The reason they're left on the table is usually not the ones we go after first. I look at the left, that bar is the total amount of time of the OR, and the right is the total amount that was used. Everything in the middle is the time that was not used. If you look at all of the drivers, instead of focusing on canceled cases, delays, cases ending early, miscalculated case length averages, big opportunity is in that scheduled downtime, which we call collectible time. And with Exchange and Collect, we're able to provide data to help make decisions in your organization. So maybe your organization has a large amount of unused time that could be linked to poorly allocated block time or a lack of releasing. iQueue can help with that. You can repurpose that time, close rooms, pause expansions, or bring on new surgeons. Maybe your capacity is already really high. You don't have much opportunity to collect from surgeons, but you can encourage a culture of releasing further in advance to create more open time, creating that circle we were talking about earlier, and offer that to increase your fill rates. So reducing that unused time, making more time in advance, and filling that those holes in your schedule can increase your room utilization, prime time utilization, increase your volume in turn. So there's many different decisions that these tools can implement and help you making decisions to improve many different metrics across the board. So with that, this brings me to the end of the presentation. Hope that you were able to learn today some insights on how we really dug in and were able to peel back the layers of the onion to say and understand where the biggest opportunities were to attack to help improve the block utilization for our customers. And hope that you've seen how with iQueue we have some tools and processes that can help do so in your organization. And with that, I would love to open up the floor to any questions from the group.
Thank you so much, Brooks, for a great presentation. As a reminder to the audience, if you do have a question, please use the questions feature on your webinar dashboard. We have some that have come in already, and those are, how frequently are metrics updated?
Yes, good question. So we actually, during the technical onboarding, will give your IT team the queries that they need to run to send us data. Reduces the technical burden on them and helps us control how often and how accurately we can update our data in iQuue. So every single morning we receive a feed of data with prior and future data, so that every single morning that volume and all the metrics are updated. And so it's as real time as it can be on a day-to-day basis.
All right, our next question is, have you found that surgeons are looking at their data and agree with what you are showing them? If so, why?
Yes, I'm actually going to go right back to this screenshot. This guy, director of a block committee, every single month held this meeting and could never get anyone to budge, and then he's been able to have ortho surgeons willingly agree to give up block. We send messages and alerts of surgeons' data directly to their phone every single week. We'll receive messages, questions about certain metrics, so that shows that they really are engaged in it. And that's one of the biggest parts of our onboarding implementation, is getting the surgeons to really dig into the data and make it a part of their day-to-day life, to actually utilize that to understand and make decisions.
All right, our next question is, it's a little bit long. This all looks great, but our IT department is telling me that they don't have the bandwidth to take on new projects. You mentioned that this is cloud-based. What does that mean for my organization in terms of IT resources?
Very good question. So definitely understand the resources the IT teams have and the amount of time it could take to work on projects like this. As I mentioned earlier, though, we actually have worked with each EHR and company, in customer, to develop these queries and scripts over time. So we hold the keys there and are able to pretty much hand those over and plug and play, run the queries, send us the data. The entire data onboarding, we commit to 10 to 12 weeks in our contract, but we've done it as fast as 2 weeks before. So it's really a process that up front, the IT team's involved for the first week or two, getting those interfaces set up, sending to us with our help, and then we do all the onboarding, maintenance, training, and maintenance of the application going forward. So overall, it really is a pretty streamlined process, and we can accommodate and help out the IT team as much as possible.
Our next question is, our schedule is full of blocks and there isn't really much open time available. How could surgeons request time that doesn't exist, or how could Exchange help us?
Yes, good question. We've had many customers that are really heavily blocked, many that are really lightly blocked, and have been able to make iQueue work for both. For those that are really heavily blocked, we really try to, one, help you use Exchange to release that time further in advance with those release reminders and the predictive capabilities we have there, encouraging that mindset of releasing time as far in advance as I can, creating more time to be opened up for others to utilize. And as well as that wish list idea where you can put your name on a piece of time, a date, and once that time is released or auto released, being instantly notified and able to know of that and request it rather than hawking and monitoring the schedule daily. We do as much as we can to unearth that supply of time and make as much open time just as much as we try to fill what is currently open.
All right, our next question is, how often do you find that surgeons use this themselves as opposed to their schedulers or admins?
Good question. On the Exchange front, it really is more so the schedulers. Surgeons have the ability on their phone to be walking down and scroll and request some time, but Exchange is more heavily used by their schedulers. But the surgeons are getting more involved in the analytics side. So like I said, we push notifications to their mobile devices, have a scorecard that they can click into and see their utilization, and try to create that culture of monitoring and staying on top of your stats as a whole, to keep yourself accountable each week, comparing week to week by week, to understand where you're improving and maybe faltering. So we definitely see a decent surgeon engagement within the application, and it's something that we aim to improve on more and more to really become one with the surgeons and helping show them that this is a tool that really can improve their day-to-day operations as an individual.
Thank you so much, Brooks, for your time today. I'd like to encourage everyone to visit today's sponsor to learn more about the products and services they provide to our industry. Please visit LeanTaaS.com. A quick reminder to the audience that you can obtain your continuing education certificate by completing today's post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE hour, and you will be able to download the certificate immediately after the survey is completed. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back soon with another webinar. Please visit ortodaywebinars.live for more details and for complimentary registration. Thank you all and have a wonderful afternoon.